Hi, everybody. It looks like we have a full house. My name is Zena. I'm a program supervisor at NYULH's Alzheimer's Disease Research Center, and thank you for coming to the Early Detection of Dementia Learn at Home talk. So just so you know, participants are muted upon entry, and following the presentation, you can unmute yourself to ask questions. You can also put questions in the chat box. So I'll just do a brief introduction of our speaker, Dr. Chodosh. He is the director of the NYU Division of Geriatric Medicine and Palliative Care and a professor of geriatric research at the NYU Grossman School of Medicine. He is also a staff physician at the VA Harbor Healthcare System. Dr. Chodosh has built the Friedman Research Center on Aging Technology and Cognitive Health. He also leads the Outreach, Recruitment, and Engagement Core of the NYU Alzheimer's Disease Research Center. So you can take it away.
Thanks so much, Zena. It's a pleasure to be here. I wish I could see all your faces, but obviously I can't right now, but maybe we get into Q&A, we'll be able to see some of you and certainly hear from you. I hope this will be both informative and fun. I'm going to take a little bit of a different tact here. I'm going to give you what I often do for clinicians with a little bit of a different twist to this, because I think it's useful sometimes to hear it from that perspective, and I think should be of great interest. So this is really about not detecting early onset dementia. This is detecting dementia earlier than we do now, which is not very good, and you'll see more as to what that's all about. So I'll see if I can make this work. So you've probably seen this slide or this graph, something like this, and this is what is projected for those individuals. Really now it's between 2020 plus and 2050, how many people there are going to be. And when you look at 2050, you can see this 13.8 as the number. And this is going up pretty dramatically, particularly in this older age group. And so the question is, why is this happening? And I think the biggest answer is this. It's about people like me populating the planet. You know, the baby boomer generation is our biggest generation. And as we've come of age, we're populating these numbers. This is not about increased risk of developing Alzheimer's disease or related dementia. In fact, the latest data is pretty good news that the incidence of Alzheimer's overall, the risk of Alzheimer's is going down. And there are a lot of factors and reasons for that, probably, that we'll get into as we go through this. So I want to do a couple of things here. One is I want to define dementia for you, and also give you a very clear, what I hope is a very clear working definition for what clinicians use or should use. But I also want to talk about what are some of the factors that are involved in our less than optimal levels of detection, why this is an issue, why it's important, and I want to use some clinical cases and give you a little bit of a bird's eye view of at least what I think is, in terms of best case approach, how we should be approaching this problem. Okay, so defining dementia, well, you know, what is it? So this is a decline in cognitive abilities that are severe enough to affect our functioning in everyday life. That involves things like our ability to remember things, to plan, to understand, to make decisions, and how aware we are of ourselves and others. This is caused by a disease in the brain that we use a fancy term called neurodegeneration, or sometimes brain injury. We see progressive neurodegenerative changes in the brain, sometimes due to injury. You've seen that through people who have suffered multiple concussions. That is a form of a degenerative process for some people who have had multiple concussions. But it's often first of all, it's the most disabling condition amongst that older age group that you saw in that earlier slide. And unfortunately, it's often a silent partner in the healthcare setting. And you probably can tell me stories as much as I can tell you about how long it took for somebody to identify the problem, not you, but the physician or other provider, and what that was like. And certainly this can go on for several years before it's actually recognized. And this here are a list of really symptoms and or signs that people have that are reflective of this condition. But let's go to something that's more of a working definition. So DSM-5, what is that? That's a really thick book that has all the diagnoses in psychiatry and many in neurology and criteria. And so if any of you have trouble falling asleep at night, I suggest you get this book, put it by your bedside and start reading it. You'll have no time falling asleep. But with that said, it does actually have some very useful material in it. And this particular definition is one that I use every single day. And it's one that we use clinically, and we actually use in a research setting too. And so what is that? To have, and this, they've changed in terms of thinking about the word dementia, they now call it a major neurocognitive disorder. And a major neurocognitive disorder or dementia is defined as having some area of cognitive ability that's declined. And these are the various areas, our ability to stay attentive to a task, to carry out a sequence of steps towards some desired goal. That's executive function. How well we keep information in our head in the moment is working memory. Our ability to use words and understand words and form sentences is our language. And then how we move and how we see things as we move. And then how we look at our environment socially. Those are things, any of those domains, which actually refer to specific places in the brain, though there are lots of places they occur, that decline. But that's not good enough. That also has to be, that decline has to be noted by, if it's you or someone else, by that person perhaps, and if not them, somebody else who knows them well, or a clinician. And that has to indicate that that level of impairment is not tiny, small, but it's really substantial. You know it when you see it. Preferably if it's documented by more detailed testing. And when I talk about neuropsychological testing, I'm talking about not a simple screening test that I'll show you in a minute, but I'm talking about something that takes, at a minimum, 90 minutes to 2 hours of testing. So that's that and a qualified clinical assessment. But we're still not there. It's still not enough. That disability, that deficit has to affect your independence in your everyday activities. If it doesn't, it's not dementia. That is a pretty clear and a pretty bright line that we all adhere to when we make this determination and when we're in the business of detecting whether or not somebody has dementia. Can't be delirium, though certainly delirium is what people get when they get acutely, suddenly confused. We see that sometimes. Maybe you've had a family member that went into the hospital and all of a sudden was confused and different. That's not dementia, that's delirium typically. But when we see that, very often, if it occurs in an older person, that can be the first visible marker of when it was being missed otherwise of an underlying dementia condition. And it shouldn't be explained by some other mental health condition like depression or schizophrenia or something like that. So why is this important? Why is detecting early important? Well, this is for many folks who are at risk, or their families and professionals all agree that when you detect this problem at a milder stage, it gives us time to adjust and prepare for the future. And most people can be quite active in planning their own care, even when they have a diagnosis of a dementia condition. But this is where the news gets worse. About 50% of people out there right now are only that half of the group that are diagnosed at moderate and severe stages. That means we have people with severe dementia who have never been evaluated or diagnosed, and that to me is just not acceptable. So early detection then also opens the right door to the right care or the best care if everyone is prepared. That means the person who's living with dementia, their family members, the doctors and those around them, and if access is equitable, and that's a big issue in this space, and I'll say more about that. Why is this? Why should we detect this? What other than planning? Well, if we don't, all of these other things are going to continue to happen, and we have no opportunity to intervene. That includes, missing important parts of your healthcare, including making errors in the medications you might have to take. If the stress of caregiving was severe for some individuals, imagine how more severe it is if no one else recognizes or appreciates the problems that are going on at home. This often leads to family conflict because spouses, sons, daughters don't understand why this person is now behaving differently. We can't take very good care of ourselves with respect to self-managing chronic diseases if in fact we have an underlying cognitive disorder, and lots of other things, including using, has been well documented, using healthcare services, acute care services at a much higher rate. Also, I alluded to this, but this gives you an idea of the emotional stress of caregiving. And here you can see that with respect to taking care of somebody with Alzheimer's disease or related dementia, it's first and foremost, it's the emotional stress more than the physical stress, unless in fact, somebody also has physical disabilities. But that should be a wake-up call for all of us. And many of these caregivers can't get the help they need if we haven't recognized that there is in fact this problem. So the goal of dementia detection, which I think you probably have sensed I've alluded to a little bit, is much more than making a diagnosis. It's really about finding a way to engage those individuals who are living with dementia and their families and join in a journey of better understanding, better support, and better care, none of which can happen without detection. So and I'm talking about myself and colleagues, and I would say, so I've already alluded that, you have 50% of people out there who aren't being detected. So why aren't we better at this? And I can make my mouse work. Partly because many of us don't understand this condition well enough. We weren't trained, going in medical school, and maybe, or we haven't kept up with the information. So we don't understand, why should I detect? How should I do it? What is it that I need to do? And who's best to do it? We're afraid of offending others, and I'll say more about that in a bit. We don't want to do a memory test or ask people questions that might make them feel like we think they're stupid when we don't. But we ourselves might feel stupid of jumping into this, into this boat when we're not sure which way to go. We're not terribly prepared, as I said earlier, and we've not had adequate training, although that is getting much better now. And often we feel nihilistic or powerless, not realizing how much it helps when everyone when this is finally talked about. And I can give you volumes of clinical experiences when I've had this conversation with patients and their families, and the level of appreciation that somebody is finally willing to have this conversation. And then finally, why would I be motivated to do this otherwise? Because nobody's really looking, because to date, we still don't have accepted quality standards to say to practices, to individuals, to systems, how well are you doing in this arena? We have those for managing blood pressure. We have those for managing diabetes. We don't have this yet for dementia, and they are greatly needed. So I talked about this issue about feeling stupid, but this process can be an affront to one's personal agency. I can't think of another condition that takes away our ability to do for ourselves and for me to be the boss of me. So we need very much to have strategies that help us guard against this affront. And I will tell you a little bit about our BOLD, B-O-L-D, which is building our largest dementia infrastructure, which is our BOLD Center, which is one of the CDC centers of excellence. And in our BOLD Center, we emphasize this approach writ large. There's also this issue of stigma in general. And so what is stigma? Well, immediately, if you look at this picture, you probably have conjured up a bunch of thoughts, immediate impressions, and much of those are unfortunately what society has given us, what our media has given us, many of which are negative, then we know nothing about these individuals, absolutely nothing really, other than that this guy's using a cane, and I don't even know if he needs that cane. Maybe he uses that cane because he wants to ward off, he's afraid of other pedestrians, and he knows if he has it, everybody will leave him alone. And so stigma is really a set of negative and often unfair beliefs that a society or group of people have about something or someone. And it can be a mark of disgrace depending on the culture associated with a particular quality. So we have to do much to address that, to know that often that's the elephant in its room. But also, dementia detection itself has enormous challenges with respect to health equity. Why? Why might you ask that question? Well, when we think about dementia health equity, we have to think about racial bias and racism we have to think about biases with respect to ethnicity as well, and what those biases then lead to. And they lead to this concept or play very much into this concept of social economic state or class. And that then leads into all of these other things that if in fact we have more or less of those things, we have far less opportunity to change. That includes our ability to, maybe we live in a community where it's really hard to find a place to even walk, or because we are of a lower socioeconomic group, we might be more isolated from others. Not necessarily. If we're using alcohol, we might have, to an excessive degree, we might have less opportunity to stop smoking, and certainly many people end up living in what we would classify as food deserts and don't have the best diet and certainly the best nutrition. And certainly that impacts our health, and that in turn will impact whether or not we end up having dementia. And that's not all that causes dementia, certainly, but we know now from a number of studies that there is certainly an important influential pathway there. And with respect to health equity, we also know that amongst individuals from Black communities, they're, at least based on these data, I'm not sure I entirely believe this, but they're 2 times more likely than whites to develop dementia. And I would argue that this delta, this difference, is really due to these social determinants of health, including less education, less opportunities for full development. And we also know that both Black and Hispanic adults, based on epidemiologic studies, have a twofold increased risk compared to whites to have mild cognitive impairment. That's what MCI is, or dementia, and I'll define that in just a minute. So when you think about this and you think about social determinants of health and all of these factors, brain health is really, it should be everybody's business. And this is really a public health issue, and public health as an entity can be a message amplifier and really put a big dent in this armor of stigma that I've talked about by educating the public about what is possible when the right care is provided in the right place. And that's what we do in our Bold Center. You can see some folks you may recognize. Actually, you probably recognize the guy towards the right, Alok, who's I think on this call right now, and Karen Marsh, who may be on this call as well, who I haven't seen. But these are the folks that work in our Bold Center of Excellence. And our mission is really to increase early detection of dementia nationwide so that we can achieve better health care and better health for all of our older adults and their care partners. And we've broken this out into 3 arenas. And so right now, if you think about this, am I talking to you? I'm focused on this left side, person, family, and community, but we work directly with healthcare providers and healthcare systems, and certainly throughout the country, public health, departments of public health. One of our strategies, which is really important, I think you all on this call can appreciate this, is the need for a diverse and skilled workforce. And that is some of the work that we have entered in now through developing training materials, workforce training, workshops, and webinars. And when you think about the workforce that's needed for dementia, this starts to become a little bit scary, because we know that between now and 2030, we need about 1 million additional direct care workers. And as the prevalence increases, there's going to be increased need for a paid workforce that's involved in doing what people like me do, but also what people in the community are doing who are providing ongoing daily care. So let's talk about the process itself, and I want to give you some examples. So these are real people, real patients that I've seen. This was a 93-year-old gentleman. This was in a VA clinic where I do a lot of clinical work. And he came in with his son. He had high blood pressure, and he had some unsteadiness when he was walking. He required some help with his daily activities. That's very important question to be asking. How do you do with things that you normally do day to day? And in particular, he's having more trouble than he used to have using appliances like the coffee maker. He didn't quite understand how to make it work. He was pushing the wrong buttons. Very social guy, and talked freely with me about the current events. And we had a great conversation. And he had a cognitive test, and we'll talk about some of those in just a minute, in his medical record. And that test showed that he was, in fact, a year prior, having some difficulties. So I started to go over the test results, and his son interjected quite emphatically and dismissive. Doc, my dad is great. And so I stopped and I said, okay, good. Well, let's talk about some other things. And I deferred further discussion. So what happened here? I'm going to ask some questions. And what are some strategies to create a therapeutic relationship? And how do I accomplish this? And what's in their best interest? So to think about this, the thing that happened here was I got intimidated. I had a sense that his son wasn't having any of this, and that perhaps he was, that what was playing in there was a threat to his dad's personal agency, and he wasn't going to let that happen. And that also said to me that we didn't really have a trusting relationship yet for me to have this conversation, because his son wasn't trusting where I was going to go with this information and how I was going to manage it. So how do I accomplish that? I need to spend some time with them and make sure that they get to know me and what my intentions are, and the fact that my considerations are what should be in their best interest. And my view of this as not what are the problems here, but what are the things that that you're doing well with, and how do we make sure that you continue to stay as healthy as you can? And that, I think, is what is in both of their interests, is to stay as healthy as they can. And if there are problems, can they get any additional resources to manage whatever difficulties his dad and the son might be having at home? And that's certainly something that we need to do to get further into what should have been at that moment an opportunity to identify just whether or not there was a significant problem, and if so, what did that look like? So I'm going to give you another individual, and this was someone who was 79 years old, and he owned a number of apartments. Actually, this was someone that back in the day when I used to work in Los Angeles, this was in the Los Angeles County area. And he came in with his wife. He came in, I think, primarily because his wife was concerned about him. He wasn't the least bit concerned. And he had, you may have heard this term, peripheral vascular disease. This is something that hardening of the arteries, something that often can happen both when you have diabetes and hypertension. This can sometimes lead to strokes. Sometimes it leads to a blockage of a vessel and needing a urgent procedure. You can present with severe pain in your leg, or you get a lot of cramping when you're walking, and it's repetitive and predictable. But so we knew he had some peripheral vascular disease, but his blood sugars were pretty well controlled, as was his blood pressure. And he had been driving still, 79, driving in LA. That's pretty good. That's a hard thing to do. I don't necessarily look forward to that. And he had no, as far as we knew, he had no tickets and he had no accidents. He wasn't returning home with dents in the car, which we see sometimes. And then the person doesn't report that or says, I don't know where that came from. And he was in a pretty traditional marital relationship. Traditional how? Well, he was the man of the house. He was pretty domineering, but she made all the decisions. And that's, I think, what we often see in these traditional relationships. So how am I going to broach what I think at this point is the need to do some assessment, because I've already got someone with a lot of risk factors. He's got vascular disease and he's got diabetes and hypertension. That tells me that he's got likely having some changes in his brain of at least a vascular nature, and that can affect his thinking and memory. So I have to come up with ways of saying this, different statements for different people, just like we all do in everyday life. I am sure that you talk in a certain way and talk about things in a certain way, and even talk about particular things depending on who you're with. That is innately human for most of us. But I also want, if I'm going to go forward and really talk about this and even do a particular test, then I want to link this to things that are familiar, because this is not familiar to most of us. Doing a memory test or drawing a clock or whatever it is you might do is not necessarily everyone's, in everyone's experiential basket. So I want to make it, this is sort of like what we do with these things. And I also want to explain, give them the heads up about, here's some of the things that we might find and the strategies we can use depending on how one does. But I also want to know whether anyone has concerns about this, so that I can address those concerns. Someone might, and in that I might anticipate when I do a cognitive test, I will always say, you know, some of these questions are really easy and some may be more difficult, because people can feel when you ask them a simple question that is easy, it can be insulting. Like, what you don't know? Like, what do you think? I'm stupid? And when people have a question that's really difficult that they can't answer, they can be embarrassed. But by normalizing this, by saying, look, you know, these, and it's true, these are questions that lots of people can have difficulty with, that addresses some of this stigmatizing piece that I talked about earlier. But I also want to emphasize the why. Why are we doing this? And that's how this process helps me be able to better address health concerns, any safety concerns moving forward, so that we end up with a better strategy. So I'll use certain statements, and we teach our learners this, our students and our residents, and sometimes providers this. You know, do you know anyone with memory troubles? Again, I'm looking for some familiarity so that though it's relatable for them. He says, yes. I says, so tell me more about that. You know, I got a couple of buddies, you know, and they've really gotten bad. Well, what do you mean? Well, they just, you know, we were playing cards and they don't even remember what came out, you know, the hand before. And it's annoying. Okay. And so what do you think about the possibility that in the future, like many people, you might develop some trouble with your thinking and memory? And you might often find, yeah, it's one of those things that really worries me. So should we talk about some things that you could do for yourself that may ensure you keep your brain healthy? And it's this notion of focusing on a healthy brain rather than a problem that I think is really important when we're thinking about increasing our ability to detect dementia. And I'll also say, you know, it's going to be helpful to me because sometimes there are medications that we might need to prescribe or conditions that can go untreated that can affect your thinking and memory. So if we have some baseline sense of how you're doing now, that will help me later to know whether something maybe I've done isn't in your best interest and we need to take that back away. So with this gentleman, we used a screening test. Now, some of you may be familiar with this word minicog. It is probably the most commonly used simple, short screening test that we use to assess thinking and memory currently. It involves 3 words, and you're asked to repeat those 3 words, and then you're asked to draw a clock and put a specific time by placing the hands, writing the hands on the clock to show a specific time, and then you're asked what those 3 words are. And so he missed one of the 3 words on recall after he drew the clock. And when he drew the clock, he had some trouble putting the numbers in a reasonable place. This is not an examination in artistry. It really is a more forgiving test of can you at least get the 12, the 3, the 6, and the 9 in their expected places around that circle, and the other numbers need to be there as well. So he had a minicog that some people would say put him on the border, depending on what cut point you would use for deciding whether this is really has a greater risk or not of having underlying cognitive impairment. But he didn't require any help with any of his basic activities, except he had been having some errors with bookkeeping, and that's what we call instrumental activities. But lo and behold, when we looked at his medications, he was taking Tylenol PM. And I don't know how many of you know what that is, but Tylenol PM is a medication that includes a drug called Benadryl or diphenhydramine. I hope none of you are using that. If you are, I think you need to stop, because it turns out that diphenhydramine is what we call a highly anticholinergic medication. That's a big word, but anticholinergic is something that as we get older, we're much, much more sensitive to. That affects the clarity of our thinking. It can affect our ability to pass water, particularly for men. It can affect our vision, especially if we have glaucoma, can make that glaucoma worse, can precipitate a fall. So we want to stop that. We also be concerned with somebody who maybe is having a little bit of difficulty with their memory, whether or not there's some underlying depression. And for him, his screen for depression was normal. And then we would do blood work and his thyroid function, his vitamin B12, which can be deficient and can have some impact on our brains, though it's usually pretty small, was normal. His blood counts were normal. And because he had diabetes, we do a diabetes test called the hemoglobin A1C that measures the average over time of what your blood sugar is like. And that's not a normal hemoglobin A1C, but it's squarely in the range of where we would want to see him for someone who's having his diabetes control. So that also looks pretty good. And he was only taking a medication that would not put him at risk for having events where his blood sugars were too low. So I wasn't concerned about that number being too low. So you could argue whether his bookkeeping put him in the realm of remember, he had a cognitive issue that maybe was affecting a functional activity, whether it put him in the realm of dementia. But remember, we had some other things to do, including stopping that Benadryl, and certainly your ability to be attentive and work with numbers. And if I give you a cloudy brain because you're taking this medication, that's going to make it harder for you. So I wasn't willing at that point to think that this was truly a dementia condition, but he was certainly at risk. But he did, squarely fit into probably a concern about mild cognitive impairment. So what is that? That is a concern raised by the person themselves. Doc, my memory is just it's not any good. I'm going to tell you why, and I want to know why. Could be observed by someone else, or it could be observed by me as a clinician. That cognitive impairment could be in one or more areas of function. These are in different places in our brain, as I mentioned. And I would not have any dependence on managing my daily activities, and I don't have dementia. Often, if we're thinking about mild cognitive impairment and we're really going to use that term, it's best to have a more detailed evaluation, which we would call neuropsychological testing. We don't always have access to that. But if you do have that, truly do, in fact, have that condition as determined and declared by detailed neuropsychological testing, those individuals will progress to dementia on average of about 1 or 2 out of every 10 per year. But remember, that's only 1 or 2, and many individuals will in fact stay stable over a number of years, and some will improve. And some of the improvement here might be based on changing their medications, might be based on improving their diet, might be based on better blood sugar or blood pressure control, might be based on better exercise and better sleep. So those are all very important factors. So I've kind of given you a heads up on all that. What should management look like for this person? And so we want to offer both therapies, but we also want to provide continuity. This is not a one and done. Go back, I would hope that, if this is a primary care physician doing this, and that there's continuity and that they can provide helpful explanations. But first and foremost, we want to stop that Tylenol. Now, if you're taking Tylenol PM, that says to me you're having trouble falling asleep. That's why you're taking it. And if you're having trouble falling asleep, now we want to understand what is that sleep problem. And you've probably heard some other talks from Dr. Rosario or others about sleep, or Dr. Gugu, and there are definite assessments that need to be done and interventions that need to be had so that we can improve sleep quality, because that's certainly very important. We talked about blood pressure and blood glucose control. We talked about diet. Excuse me 1 minute, I'm just going to disconnect this. And we talked about exercise, and perhaps equally, at least of equal importance, I want to reframe all this. I don't want to be talking about brain disease. I want to be talking about brain health. And I want a positive strategy going forward, because that's what's going to be most encouraging, and that's what's going to help people and families with their own behavior changes. So in linking this to the right care, we've got to focus on that person. And in doing that, I have to know with this gentleman that we just talked about what matters most to him. And in doing that, I want to focus on that, what matters most to him. And can I identify what he's really good at and really promote that? And what the risks are, and make sure that I address those as well. It's also really important. Now, we have many people in New York City who live alone and do not have friends. Maybe hopefully they have one person. Like on Tuesday, I was in clinic, and it was the guy who lived 1 floor above, and he's lived in this building for 60 years. And that's his one and only and best friend. Thank goodness that he has that person, because he had nobody else. But we would like to include someone else as much as possible at every step of the way. And to the degree that they're really involved in that person's life, like a family member might be, particularly a spouse, a son, or a daughter, we want to listen to what they have to say as well. So it's really important that we identify these people, what their roles are, and as a clinician, we record that information. So for all of you, it's really important that your doctors know. You may well be a care partner for someone else. And does your own doctor know that you do this? And does the doctor who cares for your loved one know that you are that person in that role? Because I need to then be alert to signs about your stress and strain and conflict and have a plan to help. Because if I can't help you as a care partner, then I'm in a bit of trouble because my patient may well be dependent upon your ability to help them. A care plan together includes a safe and healthy living environment. Easy for me to say, sometimes hard to achieve. Activities and identifying those activities that will sustain those relationships and engagement. Sometimes very personalized and supportive services are needed, but really focusing on the necessary healthcare and making sure that everybody understands why. Why? Because we want to protect your brain. We want to manage morale, because morale can be low, particularly when people are struggling with problems with thinking and memory. So we want to pick people back up. We want to address a mood disorder if there is one. We want to make sure that their medical care is optimized, like getting rid of that Benadryl, that Tylenol PM, and supporting you as a care partner. And in doing so, easing all of these other health-related social needs. So why are we spending so much time on all this? Well, when you think about it, our brains are essential for everything that we do. And I'm going to pivot here for a minute because we're going to get into a little bit to what does this look like in terms of some of the other work that clinicians like myself might do in detecting dementia. And that's using an instrument or a tool, some standardized set of questions and strategies that will give me an answer that I can repeat across individuals and then start to understand a problem with more reliability. And usually if I'm doing this, I want a family member present, although I don't want them to provide the answers on the test to help that person answer a question, but it's good when they're present. I want that person there because they may provide some information that I need, and I'll talk about that in a minute. But when I do this kind of thing, I've got to tell people, if somebody just starts asking you questions like, so tell me what day it is and all that, your first question to them should be, well, what, you don't know? Because they haven't really given you a rationale for why they're asking these questions, and they should. They should also normalize this. This is something that I do with all my patients. These are questions that some are hard, some are easy. And I also want them to know why I'm doing this, which really speaks to what am I going to do with the information, okay? So what are screeners? These are the tools I talked about. And there are really two kinds of approaches that we use clinically. One is what we call performance-based. That's when I ask you to do something like the mini cog, and I'm going to actually show you these instruments in just a second. And the other are what we consider more functional-based screeners or informant screeners. Those are instruments that we use that directly focus on function, but they use the observations of another. We could use a functional-based screener, and I could ask my patient, so do you have any trouble with with balancing your books or, managing money? And they might have that problem, but they may or not tell me that they have that problem or be aware, in fact, that they have that problem. And we see this a lot with financial abuse and people getting other people to give them money when they shouldn't be. So those are things like the IQ code, but we can also do this pragmatically, and that's the common sense screening, and I'll say a little bit about that. So this is the mini cog. This is what it looks like, at least on a piece of paper. And these are different versions of 3 items. We typically use banana, sunrise, chair. Can you repeat that back to me? And then I'm going to ask you that later. And then I have somebody draw a clock, usually having a circle that's big on the page is what we want to do. And then I ask them to put the numbers in. And I say, can you please put the numbers in and then put the hands in there to tell me the time that's 10 minutes past 11. Okay. And so that's the clock. It gives us a lot of information. Perhaps if we have more time, and another time I can go into why that clock is so important to me and many of us as a tool. And then they draw the clock, and then I say, can you tell me those 3 words? That's the mini clock. Okay. An informant questionnaire, one example is what's called the IQ code. And you can see that there's a list of questions here. This is all of them, but it's a list of questions that are asking another person to tell me, hopefully that person has known them for a long time. We will punt if somebody has only known someone for 2 or 3 years because they might have detected those changes. But we ask them about various things that are going to tie into their day-to-day functioning, right? Including, remembering where things are usually kept, learning how to use a new gadget or a machine around the house, making decisions, handling money for shopping, etc. And we want to know over a time period that they've known them, has it not changed at all? Has it gotten a little better, or has it gotten worse? And then that gets scored, and then based on an average number, it gives us an idea of, given population standards, what's the likelihood that that score then represents whether or not this person really has a challenge, in this case cognitive impairment, or not. The pragmatic approach, which I mentioned, is really about just focusing on day-to-day. Particularly, we would use this for somebody that didn't go through our educational system or another. There are lots of folks who are well educated in other ways, but they may not be school educated. And there's a bias in these tests towards, particularly Minicog and others, towards a school-based education. So if you've gone far in school, you're more likely to do well on that test, regardless of what your underlying cognitive ability, a cognitive state is, than if you haven't gone to school or gone very far. So we would ask questions like about day-to-day activities. And so I might hear a story about that problem using the coffee maker. And then I want to know, well, is there a problem because you're having a trouble with your eyesight? Or is it a problem because the buttons are confusing to you and you used to be able to do that? Or maybe using the phone now has become more difficult, or even sometimes, dad doesn't answer the phone anymore. Well, why? Well, he can't figure out where to push the button to answer. And it's not because he has hearing loss, because we certainly want to investigate that as well. So when we have these evaluations, this should be a conversation. And if it is a conversation, words matter. If I say, if you come away with anything from this, come away with that the words people use really matter. So what's most important to you right now? What have you done in your life that you're most proud of? Are you concerned that the things that you do are getting harder, and why? And do you ever worry about your memory? And then if I've got somebody else in the room, I want to know. I'm never going to make that assumption because I'm going to be wrong sometimes, and that's really embarrassing, if not insulting to the other. But how are you two related? And we're not related at all. Oh, okay. Well, so how do you know each other? And would it be okay? I will ask permission always of the person who is my patient. Would it be okay if I asked Jane about how she thinks you're doing? Because I'm not going to ask her without his permission. And over the course of the week, do you do the things? I would then ask, do you do anything to help Tom with his day-to-day activities? So what should happen after detection? Well, that's where we talk about making sure there's continuity and we develop a care plan. And that's what I had said to you earlier about letting people know and helping them figure out what's best for them to do in their lives so that they can stay healthy and get healthier. And those should be things that you enjoy. And the things that we would be talking about that can be very general things are often things that are also good for your brain, and we want to use that kind of language. And we certainly want to be positive and encouraging, because we can and should be, and because there's always the opportunity for things to be better, even in what seems in the moment like the most dire set of circumstances. The tools that we use for diagnosing this condition, I've shown you, those cognitive assessments, and sometimes more detailed if I have a neuropsychologist on hand. Depression screening is important. We do use brain scans, and those brain scans are to look for changes in the brain. It could be areas of the brain that have shrunken from their usual size. We can see vascular disease on the brain. Sometimes we see a mass in the brain that isn't a dementia, but is in fact another problem. And typically we want to look at these scans when we're not sure from all the other information we have, or we're finding a neurological finding on exam that would suggest something that's more specific. Now, you may have heard this word biomarkers, and these are other tests and things that people get from us and measure, including those brain scans, but doing a spinal tap or a lumbar puncture, using blood tests. There are now blood tests that measure amyloid or tau. These are some of the things that occur in our brains that are harmful to our brains, but can circulate blood as well. And we're still working on the precision of those measures. So that is still a bit, under some debate as to whether those should be in usual clinical care. But we also want to do laboratory testing looking for those things that are reversible. And we want to be sure that we focused on those matters that are psychological and social. And very often, particularly when it's in an early course of a problem, we have to wait. We have to watch. We have to follow people for progression. And it is sometimes that progression or a lack of progression that gives us a better answer. So I'm going to, close pretty soon on this, and I think the next slide. But to say that, it's always been my motivation that you should be able to get this care in the primary care space. And we're working hard through the Bold Center to ensure that primary care providers are equipped to do this. The basic things that I talked about today, they sometimes require more specialized tests, but often they don't. There should be time to confirm. And then when we have something that is more unusual or challenging, that's when first and foremost we should be thinking about a specialized referral for further evaluation. And when we are with individuals, with persons living with even without cognitive impairment and a family member, it's really important that we contextualize our conversation by first knowing what their concerns are, what their prior experiences are, explaining what results tell us and what they don't tell us, and ensuring that we have those next steps to build trust through that anticipation of continuity. I think the future is very bright for all of us. And I think together, both in our Bold Center, but also in our Alzheimer's Disease Research Center, for many years now, we are absolutely making a difference in this journey towards preventing this disease and improving the conditions for those who have it. So thank you very much. And if there's time for questions or conversations, I can take this off, stop sharing and take those.